Number 3, AB 1696, Medi-Cal Tobacco Cessation Services. Good afternoon.
Mr. Chair and Senators, first I want to accept the committee's mock-up amendments. AB 1696 is similar to AB 1162 of last year, but it also streamlines the services offered by the Smokers Helpline, a useful resource in the fight against tobacco dependence. Medi-Cal beneficiaries face higher smoking rates and treatment barriers, like long wait times and fewer primary care doctors. Studies have shown that comprehensive tobacco cessation coverage increases successful quit attempts, lowers hospital admission, and decreases long-term health care costs. AB 1696 enacts state and federal recommendations regarding tobacco cessation plan and codifies these requirements by covering 4 quit attempts and 3 types of counseling for Medi-Cal beneficiaries. Existing DHCS policy prohibit managed care plans from requiring counseling in conjunction with treatment. The intent of this bill is to remove barriers to treatment and to reflect existing policy of DHCS. This bill will streamline the Smokers Helpline and the data collection process to obtain better tobacco use rates. This will save lives and lower health care costs for Californians. For these reasons, I ask for your aye vote. Today with me is Callie Haft from the American Heart Association and Lindsay Freitas from the American Lung Association.
Good afternoon, welcome, and please proceed.
Good afternoon, Chair and members. Lindsay Freitas with the American Lung Association in California, and we're here today as proud co-sponsors of AB 1696, which would ensure Medi-Cal members are receiving the help they need to quit smoking for good. Since 2008, the American Lung Association has produced a report called Helping Smokers Quit, which highlights why it's so important that smokers have help to end their nicotine addiction. Helping smokers quit not only saves lives by improving one's health immediately, but also saves money from lowering healthcare costs, increased workplace productivity, and averted premature death. However, in order to realize these benefits, every smoker needs access to a comprehensive tobacco cessation benefit, and quit smoking treatment must be provided at no cost and be easy to access. As our report indicates, too many states have policies that make it harder for Medicaid enrollees to access treatment, like limiting the quit attempts per year and creating barriers to access medications that assist in quitting. This is particularly disturbing as Medicaid members have higher rates of tobacco use than the general population. The Surgeon General has concluded that today's cigarettes are more deadly and addictive than ever, which makes it even more vital for tobacco users to get the help they need to quit for good. AB 1696 would ensure all eligible Medi-Cal members are put into the best possible position to succeed by providing a comprehensive tobacco cessation benefit and removing barriers to this treatment. We respectfully request your aye vote.
Thank you. Anyone else in support?
Mr. Chair and members, Callie Haft on behalf of the American Heart and American Stroke Association, proud co-sponsors of this measure. You've heard from my colleague why this bill makes necessary changes to Medi-Cal to ensure a comprehensive cessation benefit exists for those wanting to quit their nicotine addiction. So I'll briefly touch on some additional policies the bill puts forward. Using existing dollars, the bill authorizes DHCS to enter into an agreement with the Department of Public Health for the California Smokers Helpline to directly furnish nicotine replacement therapies, which Medi-Cal already must cover due to ACA implementation. Medi-Cal callers would be able to call the helpline and have their prescription sent to a local pharmacist without having to go into the store. So this is essentially one-stop shopping and allows for smokers to access their medications more quickly in a more efficient manner, which we hope will decrease costs and increase cessation utilization in Medi-Cal. And lastly, the bill asks that the Department of Healthcare Services collect smoking and tobacco use cessation rates among adults enrolled in Medi-Cal managed care plans in its healthcare effectiveness data and information set, also known as HEDIS. This is important because we currently do not know the actual smoking rate in Medi-Cal, and obtaining this information will better help determine whether or not cessation benefits are effective and better ways in which to help beneficiaries quit. We believe the bill will help and shrink the $3.5 billion Medi-Cal spends every year to treat tobacco-related illness and disease, and ask for your support on this measure.
Anyone else in support, state your name and position.
Chair and members, Kimberly Chen with the California Pan-Ethnic Health Network in strong support.
Tim Gibbs, American Cancer Society Cancer Action Network, proud co-sponsor.
Kat DeBerg, Health Officers Association of California, in support.
Jasmine Gordon with the California Black Health Network in support.
Jerry Jaffe, representing the California Chronic Care Coalition, in support of the bill.
Tim Madden, representing the California chapter of the American College of Emergency Physicians and the California chapter of the American College of Cardiology in support.
Amber King with the Association of California Healthcare Districts, in support.
Teresa Anderson with California Academy of PAs in support.
Justin Garrett with March of Dimes in support.
Michelle Gibbons with the County Health Executives Association. We represent local health departments throughout our state in support.
Adrian Mohammed with the Union of American Physicians and Dentists in support.
Elizabeth Landsberg, Western Center on Law and Poverty, in support.
David Hilton, American River College Student Senate President, and 6 months, 22 days quitter. I am in support.
Thank you. Opposition?
Good afternoon. I'm Jennifer Alley with the California Association of Health Plans, and we'd like to thank the author and their sponsor for working with us on the bill. There have been a number of amendments that have made it a little bit better, and we appreciate their reaching out and being willing to continue the conversation. At this time, however, we are unable to remove our opposition. This bill does exceed existing Medi-Cal policies, and it's our understanding that it goes into effect immediately, which means any of these changes may not be included in the 2016-17 Medi-Cal rate, which is always a problem for our members when they have to absorb the cost for additional new benefits that are not in their rates. Thank you.
Chair and members, Kathy Mossberg, representing the local health plans of California, the 16 nonprofit plans around the state, and we are in a similar position. While we do agree that the bill has been modified and gotten into a better place, we do certainly provide smoking cessation benefits to our beneficiaries now. We do disagree with where this bill goes and beyond what DHCS has put into place. They did put those policies into place in late 2014. We started implementing them after that, and really in 2015. We believe that what they put in place is effective and does work, but would say as well, in agreement with my colleague here, that in going beyond that, we do have concerns around it not being able to be satisfactorily put into our rates in time. Thank you.
Anyone else? Questions, comments? Seeing no questions or comments, do we have a motion? Moved by Senator Pan. Would you like to close?
Thank you, Senators. I appreciate the consideration of this bill. I think what we're trying to do is create opportunities and access to certainly folks who are on Medi-Cal and have the need for additional options as everyone else, and I do appreciate your consideration and ask for your aye vote.
Thank you. We have item number 3, AB 1696, do pass as amended to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, no. Pan. Pan, aye. Roth. Wolk. Wolk, aye.
Currently at 6-1, we're going to place that bill in call. Why don't we act on the consent calendar, item number 5, item number 11, item number 17, moved by Senator Wolk. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye. 7.
Currently 7, we'll place that bill in call. We're at item number 4, AB 1763, Gibson Healthcare Coverage, Colorectal Cancer Screening and Testing.
Good afternoon, Mr. Chairman and members, senators, excuse me, the wrong house. Thank you for allowing me to present Assembly Bill 1763, which seeks to improve access to care by removing the cost barriers for colonoscopies for adults ages 50 to 75 and high-risk individuals. I would like to start off by accepting the committee's amendments and thank the committee and the chair for working with us on this bill and strengthening this bill that's before us today. Colon cancer is the second leading cause of cancer death in the United States and the third most common cancer in men and women. Colon cancer is a preventable, treatable, and beatable disease, but only with proper screening. Standard screening for colorectal cancer includes a stool, blood test, and a colonoscopy. Many individuals opt for the simpler one, the non-invasive stool testing for their option of treatment. However, if there's an initial test comes back positive, a follow-up colonoscopy is required. The average cost for a colonoscopy is $913, and this cost can create a barrier for many. AB 1763 seeks to remove the barriers by eliminating the cost sharing for a colonoscopy, increasing access to screening for a colorectal cancer will catch cases and prevent and also provide long health outcomes for the individuals. It is essentially that we provide patients equal access to all of the screening options necessary to achieve the high screening rate, which can be accomplished by removing the cost barriers for the screening. Here with me to provide supporting testimony is Tim from the American Cancer Society and the Action Network, Dr. Anderson, to provide supporting testimony.
Thank you, Dr. Hernandez, and member of the Health Committee. Thank you so much for allowing me to speak about AB 1763 and what it can do if it becomes law. I'm Dr. Daniel Anderson. I'm president of the California Colorectal Cancer Coalition, and we're a proud co-sponsor of this bill, and this bill will help us in our mission, which is to save lives and reduce suffering from colon cancer in all Californians. In 2013, 14,600 Californians died of colon cancer and or got colon cancer, and 5,157 got colon cancer, died of colon cancer. This is a tragedy since colon cancer has the most effective screening tests of any cancer. Unscreened, you have about a 6.7% chance of getting colon cancer. So someone on this stage would get colon cancer if you remain unscreened. And 1 in 35 will die of colon cancer. With screening, colon cancers are prevented by we remove the polyps before they become cancer, and we find the cancers at an early stage. The 2016 U.S. Preventive Services Task Force guidelines, published just last week, said that the death rate would drop from 2.8% to 0.5%. So instead of 1 in 35 dying of colon cancer, it's 1 in 200. What's more important, it means we only have to screen 50 people to be in a screening program in their lifetime, and they will prevent 1 colon cancer death. So, in spite of this evidence, only 65% of the Californians have been screened. What's important for you to know and everyone to know, there's not one best screening test. It's a test people will do, and most people will do the FIT test at home rather than a colonoscopy. And so by offering this bill, makes it where there's no financial disincentive to doing the fecal test at home. And now with the 2016 guidelines, there's a fecal test that looks for immunochemical human blood in the stool. There's also the one that looks at DNA in the stool. They've also approved the CT colonography, which is done in the hospital. All of these tests have a positive rate, and they pick out the people at high risk that have to go on to colonoscopy. This bill would remove the co-pays for those colonoscopy and the cost sharing. We know that when you put financial barriers in front of someone, it reduces uptake of screening, and this helps remove financial barriers and will get more people screened. And finally, I know you're quite concerned about the cost of colon cancer screening and any additional costs that this bill would produce. The California Health Benefits Review Program analysis of AB 1763 on page 24 has this statement. Chabert estimates that there will be no cost savings or offsets in the first 12 months after enactment. However, some model-based studies have found that colorectal cancer screening can become cost-saving in the long run, mainly because of the rising costs of colon cancer care. The quoted reference is one that showed that FIT testing, the fecal immunochemical test at home, put $191 back into the healthcare system for every person that goes through that as a screening program. And this bill will increase the number of people that go into the FIT test screening program. By voting for this bill, you will increase colon cancer screening rates and save lives. With increased use of the FIT test, we can put money back into the healthcare system. And so for all Californians, I'm requesting your yes vote on this bill. Thank you very much.
Anyone else in support? If we can just try to keep the testimony germane and try not to duplicate. Thank you.
Hi, this is Tim Gibbs with the American Cancer Society Cancer Action Network. We're a proud co-sponsor. So the Affordable Care Act requires that all private insurers cover preventative services that receive an A and B rating from the USPSTF without patient cost sharing. The USPSTF is an independent volunteer paid panel of national experts in preventative evidence-based medicine and primary care that provide evidence-based recommendations about clinical preventative services. The USPSTF has assigned colorectal cancer screenings in this bill an A rating. So high sensitivity fecal occult blood tests or a FIT test, as Dr. Anderson was talking about, are effective non-invasive screenings that are more cost-efficient than colonoscopies. However, a positive result that requires a follow-up colonoscopy be provided. So the USPSTF colorectal cancer screening guidelines specifically state that follow-up of positive screening test results require colonoscopy regardless of the screening test used. As such, the colorectal cancer screening test is not complete until patients with positive results receive the follow-up colonoscopy to rule out the presence of cancer or precancerous polyps. ACS CAN advocates for evidence-based screenings that help reduce cancer incidences and mortality. The overall reduction of colorectal cancer incidence and mortality rates in the U.S. over the last few years has largely been attributed to an uptake in preventative screenings. So eliminating out-of-pocket cost sharing for follow-up colonoscopy after a positive stool test will eliminate a significant barrier to colorectal cancer screening. For these reasons, we ask for an aye vote.
Thank you. Anyone else in support?
Kat DeBerg with the Health Officers Association of California in support.
Thank you.
Mr. Chair, members, I'm Fred Note. We're representing the Association of Northern California Oncologists and the Medical Oncology Association of Southern California in support. Thank you.
Thank you.
Mr. Chair, members, Mike Carpenter on behalf of the California Life Sciences Association, support.
Jasmine Gordon on behalf of the California Black Health Network in support.
Teresa Anderson on behalf of California Academy of PAs in support.
Thank you. Any opposition?
Back.
Good afternoon. I'm Jennifer Alley with the California Association of Health Plans. We would like to thank the author, staff, and the Senate committee analysis for the amendments that have been taken throughout the process. The bill is in much better shape than it was when it was initially introduced. However, we are unable to remove our opposition to this bill, not just because it increases premiums, but because we don't believe that the secondary test that it requires was included in the United States Preventative Services Task Force initial screening requirements, which per the ACA have no enrollee cost sharing. And so that's why that there's going to be the increase in premiums. And it is kind of exceeding the screening requirements according to our members of what they're currently required to do. Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We too are concerned about the potential premium impacts and the potential for it exceeding the essential health benefits, and for those reasons we remain opposed to the bill. Thank you.
Thank you. Anyone else in opposition?
Yeah, John Winger on behalf of America's Health Insurance Plans. We'd echo the comments of CAP.
Thank you. Questions, comments? Seeing motion by Senator Pan, would you like to close?
Thank you very much, Mr. Chairman and Senators. I want to thank those who provided supporting testimonies. This bill, in fact, received bipartisan support, and I respectfully ask for your aye vote.
Thank you. This is item number 4, AB 1763, due passes amendment to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, no. Pan. Pan, aye. Roth. Wolk. Wolk, aye.
Currently has 6. We're going to place that 6-1. We'll place that bill on call.
Thank you very much.
Thank you. We're at item number 6, AB 1831, low healthcare coverage, prescription drugs, refills. Good afternoon, Assembly Member.
Thank you very much, Senator. Assembly Bill 1831 will provide refill coverage for covered topical ophthalmic products after 75% of the expected days of use. Early refill is of particular interest because of the dispensing and administering of such products. With me today is Kara Korches with the California Optometric Association in support.
Thank you. And we have support on both sides. Please proceed.
Good afternoon, Mr. Chairman. My name is Kara Korches. I'm here today on behalf of the California Optometric Association in support of AB 1831. Topical ophthalmic products such as eye drops or ointment are commonly used to treat a variety of eye-related conditions such as glaucoma, whether it's a shaky hand or simply flinching right before the drop hits your eye like I commonly do. This is one reason why eye drops are early, have depletion too early. Furthermore, glaucoma patients are often elderly and run out of their drops too soon. So even with the patient with full insurance, if they run out of their drops too early, they're left with the choice of either paying the full cost of the prescription out of pocket or just going weeks without their needed medication. Furthermore, Centers for Medicare and Medicaid Services issued guidance recommending early refills for eye drops in Medicare Part D, and numerous other states have enacted similar legislation. Therefore, I respectfully request your aye vote.
Thank you. Anyone else in support? Opposition?
No opposition. Not exactly opposition. John Winger on behalf of America's Health Insurance Plans. We'd like to thank the author staff, and the sponsors for working with us on the bill. We are officially removing our opposition. Thanks.
Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We too appreciate all the hard work of the author and sponsor, and we'll be removing our opposition. Thank you.
Jennifer Alley with CAP. We're also removing our opposition for the bill. Thank you.
Thank you. We have support on both sides. Any questions, comments from any members? We have a motion moved by Senator Wolk. Would you like to close?
Thanks, Senator, for your expertise on this issue. I respectfully ask for your aye vote.
Thank you. This is item number 6, AB 1831, due pass to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye.
That's correct. It's 7, enough to get out, but we're going to place that bill on call. I believe we're going to do number 20, AB 2821 Chu, and I want to thank Assemblymember Wood for allowing Assemblymember Chu to go ahead of him. Would you like to come up? I understand you have some obligations you need to get to.
I want to thank the chairman as well as the chairman of our Assembly Health for their indulgence. I appreciate your consideration of AB 2821 to establish the Medi-Cal housing program to continue to help shift the paradigm of how we serve our state's homeless through an opportunity created by the recent 1115 Medi-Cal waiver, our federal approval. As we all know, those who are homeless often cycle through living on the streets, emergency room visits, inpatient admissions, and nursing home stays. Our homeless cost our public systems an average of $3,000 per month, 2/3 of which consist of healthcare costs. We also know that a roof over someone's head, particularly in supportive housing, is much better for that person's health, and vice versa. Being homeless on the streets, exposed to the elements, without connection to community or services, unable to obtain sufficient rest, follow a healthy diet, store medication, or regularly attend health appointments drives up healthcare costs. The recent 1115 Medi-Cal waiver included the new Whole Person Care pilot program, which for the first time allows federal funds to be used for wraparound services. While our state request to use federal matching dollars for rental assistance was turned down, this bill would provide one-time funding to pay for rental assistance. Our bill would also require counties to compare the healthcare costs of individuals in the pilot when they're homeless versus when they're housed in supportive housing, a key component of this bill. We know that evaluation and analysis of how we invest in different strategies for homelessness is critical. This program is part of our Assembly budget's request for affordable housing, and we know that the legislature and the governor are still working to reach an agreement on housing in the budget. We're hopeful that this proposal will become part of the deal. With that, I want to turn it over to our co-sponsors for their support.
Thank you. Please proceed.
Good afternoon. Sharon Report with the Corporation for Supportive Housing. As Assemblymember Chu mentioned, homeless people incur disproportionate Medi-Cal costs. They typically fall into the top 5% of those using Medi-Cal for acute care needs. Evidence shows people who are homeless develop chronic health conditions which worsen as long as they remain homeless. While services to homeless people to get them housed and remain stably housed are critical, evidence shows that hospitalization is required among people who are homeless, even when they're receiving a very rich array of services. As long as they're homeless, their health conditions continue to deteriorate. Housing is the solution to more effective use of our healthcare system due to homelessness. AB 2821 acknowledges what DHCS requested in their 1115 waiver application, which was the ability to use funding for rental subsidies to get people to achieve better health outcomes at lower costs. In fact, this proposal is complementary to what DHCS has requested, as well as HCD. Which would be the two agencies administering the program. HCD has also requested rental subsidies in the past through their suggested amendments to the No Place Like Home initiative. Unfortunately, that was not included in No Place Like Home, but we are hopeful that this program can provide the rental subsidies that they feel like we need to get people healthier and housed. Data shows that Medicaid beneficiaries who move from homelessness to housing can decrease their Medi-Cal costs by up to 60% and save about $8,000 a year over the cost of the program. The program would require an evaluation to determine changes in healthcare costs, and we would hope that this evaluation could lead to future funding and reinvestment in the program. We urge your aye vote to create a program that would result in better health outcomes, better care, and lower costs. Thank you very much.
Thank you. Anyone else in support?
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty here in strong support. We think the state absolutely got it right when they argued to the federal government that the federal government should help give federal matching dollars, because we know that homeless folks who are on Medi-Cal have increased health care costs. We appreciate the chair's leadership in authoring the waiver bills, the whole person care. This will fit in perfectly with the whole person care pilot by actually providing the rental subsidies along with the supportive services. I think too often we're in our silos, and it's very important to look at the whole person needs of homeless people on Medi-Cal. We urge your support. Thank you.
Thank you.
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians, in strong support.
Thank you. Anyone else?
Tam Law with Health Access and Support.
Megan Brightwell on behalf of California Health Plus Advocates in support.
Thank you. Opposition? Questions, comments? Seeing no questions or comments, we have a motion by Senator Wolk. Would you like to close?
Respectfully ask your aye vote.
Thank you. Would item number 20, AB 2821, do pass to Transportation and Housing? Call the members.
Hernandez? Aye. Hernandez, aye. Nguyen? Hall? Mitchell? Mitchell, I. Monning. Monning, I. Nielsen. Nielsen, I. Pan. Pan, I. Roth. Wolk. Wolk, I.
Thank you.
Thank you.
6-0.
We currently have 6. We'll place that bill on call. We're at item number 7, AB 1863 Wood, Medi-Cal Federally Qualified Health Centers, Rural Health Centers. Good afternoon, Mr. Chair.
Good afternoon, Senator and Chair, Mr. Chair and members. AB 1863 adds marriage and family therapists to the list of healthcare providers that qualify for a face-to-face encounter with a patient at a federally qualified health center or a rural health center for purposes of a per-visit Medi-Cal payment under the prospective payment system. Marriage and family therapists are recognized Medi-Cal providers and are able to provide care in county health plans, Medi-Cal managed care plans, and as Medi-Cal fee-for-service providers. This bill will bring some parity throughout the Medi-Cal delivery system by allowing reimbursement to clinics for their visits. Behavioral health and substance abuse services are essential care benefits under the ACA. The inclusion of these services under ACA dramatically expanded coverage for millions of Californians. There are approximately 600 FQHCs and 350 rural health clinics in California. They are largely nonprofit clinics. Because they are safety net providers and make their services available regardless of a patient's ability to pay, their continued survival depends heavily on the stability and adequacy of Medi-Cal. In my district in Northern California, clinics are not just a safety net, they provide a significant proportion of the primary care received by my constituents, up to 50% of the care in my district through FQHCs. Within a primary care setting, research indicates that up to 26% of patients have some mental health disorder. There's clearly a need for these services in clinics both in my district and throughout the state. I respectfully ask for your aye vote, and I have witnesses here in support.
Thank you. Please proceed.
Mr. Chair, members, Tim Shannon, representing the California Association of Marriage and Family Therapists, who are a co-sponsor of this bill. I'm just going to turn it over to our Executive Director, Jill Epstein.
Hi, good afternoon. I'm Jill Epstein. I'm here on behalf of our 32,000 members around the state. Mr. Chairman, I want to just acknowledge your comments earlier, appreciating that you're looking at improving services to patients across the healthcare spectrum. So this bill ties in really nicely to that. As you just heard, AB 1863 would add licensed marriage and family therapists to the list of reimbursable healthcare providers at FQHCs and RHCs. Licensed marriage and family therapists are expert mental health providers with training that includes supervised practicum, where they not only treat and diagnose a variety of mental health issues, but also connect people with community resources that deliver services and support. Marriage and family licensing law specifically states that practicums are encouraged to include marriage and family therapy experience in low-income and multicultural mental health settings. As you just heard, Assemblymember Wood note, 26% of patients have some mental health disorder. The Affordable Care Act has made treating mental health and substance abuse disorders an essential health benefit and greatly expanded the number of Californians who can access health care. Thus, the training of marriage and family therapists, coupled with their approved provider status under Medi-Cal, makes them logical and qualified providers to help FQHCs and RHCs meet increasing demand and improve access to mental health services. I'd now like to pass it on to J.M. Abosovich, a licensed mental health marriage and family therapist working extensively with FQHCs.
Good afternoon. I was formerly the Director of Behavioral Health for Clínicas de Salud, which is in the very southeast part of the state, and now currently I'm with Neighborhood Health Care, which is in the San Diego, kind of east, the southwest part of the state. They're both FQHCs, and one of the issues that I wanted to bring up is we had a very difficult time being able to recruit mental health clinicians to work in our clinics with the integration of behavioral health into primary care, which is a federal mandate and is actually a very much a health cost savings in the future. To give an example, when I was at Clínicas, we had 14 clinics. I was only able to staff 5 of the clinics. We had 11 positions open that I couldn't fill. The 5 were filled with LCSWs. I couldn't find any more LCSWs. And then with Neighborhood Health right now, we have 7 positions open that we can't fill because we can't find LCSWs to fill those as licensed psychologists. The other thing that's an issue for me is that this is an excess issue for patients because it's a core benefit that's the ACA's mandated, and if we don't have the clinicians to provide the care, then they're having an access to care issue as well. And as you guys know, behaviors are what it's all about. Healthcare, the basic tenet of health is behavior. If you don't have good behaviors, you don't have good health. So if we look at behaviors, it increases healthy people, which decreases costs. Thank you.
Thank you. Anyone else?
Mr. Chairman, members of the committee, Christy Bauma on behalf of California Health Plus Advocates, an affiliate of the California Primary Care Association. The witnesses and our author were extremely thorough, so I will say that FQHCs and rural health centers urgently need these practitioners to meet the demands out there and provide the access that's federally mandated, so we urge your support.
Thank you.
Amber King with the Association of California Healthcare Districts in support.
Anyone else?
Michelle Gibbons with the County Health Executives Association of California in support.
Michael Radigan on behalf of the Board of Supervisors, Santa Clara County in support.
Thank you.
Les Shepard representing the American Association for Marriage and Family Therapy in support.
Thank you. Opposition? It's on, but it's not working.
I'll move.
I think it's working now. Try it.
On,
Try it.
working now?
Yeah,
Okay,
there it is.
great. So Rebecca Gonzalez, National Association of Social Workers, California chapter. We are here in opposition. We're opposed for several reasons. We do believe that there is a ready supply of social workers to fill these positions. Currently, every year, 10,000 social workers are graduating with BSW and MSW programs. There are also 10,000 social workers that are in the pipeline to become LCSWs, and there are currently 15,000 LCSWs in the state of California. Social workers are trained at almost every CSU in California and at 2 USCs. We also have programs in many rural areas of the state, such as Humboldt, Fresno, Bakersfield, and San Bernardino. And we are also committed to working with the clinics in order to help fill these positions, and we believe we could do that through our association and also through the schools of social work. Secondly, our other main reason is it has to do with the way that social workers are trained. We feel that we are the best clinicians really to work in these kind of culturally diverse settings with clients from impoverished communities. Social workers are extensively trained not only on dealing with the pathology of an illness, but also looking at the whole person and the person and the environment perspective. So for example, if a homeless person is schizophrenic, you can't just treat the schizophrenia, you have to connect them to services. While in social work schools, social workers have extensive internships and where we are trained on providing these services, all of these services to the community. So for those reasons, we are in opposition.
Thank you. Anyone else in opposition?
Mr. Chair and members, Amanda Levy on behalf of the California Psychological Association. We're also opposed for many of the reasons previously stated. Psychologists have been moving towards training in the integrated model to work with primary care, and we really in the last year or two have seen many programs pop up and that include internships in these clinics and feel that we're the best trained to deal with these patients in these facilities. We're also been supportive of any programs to increase loan repayment to individuals who are working these facilities. Our numbers are there. They're graduating in very high numbers, and many of our psychologists who work on these staffs look to hire psychologists if the budget allows, and we would like to see that model continue.
Thank you. Anyone else in opposition? Questions, comments from? Seeing no questions or comments, Assembly Member, would you like to close?
Yes, thank you very much, Senator and members. I'd just like to say if there is such a great supply, I wonder where they are, because they're certainly not in rural California where we need them. These providers are already accepted as Medi-Cal providers in county health plans and managed care health plans and fee-for-service providers. We're simply asking that they be able to bill through FQHCs. So I appreciate that there may be a disagreement over the supply, and but I'm just saying, where are they? And we'd love to have them in our district if we could get them there, but we have a lot of empty spots. So I would just respectfully ask for your aye vote.
Thank you. Do we have a motion? Moved by Senator Monning. Item number 7, AB 1863, due past appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye.